One important thing to remember is surgery at sea is not just for the Navy. More and more, we are training and integrating Army surgical teams on our warships. We're integrating our medical services. We're practicing with Air Force units. Maritime surgery is a joint problem, and more, we're going to be working in that environment together across the services.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care. Welcome again to Frontline Surgery, Mastering Military Trauma Care. I'm Joshua Dilday. I'm joined by my co-moderator, Jay Yelon. And this series, just to review, this series prepares the early military surgeons for the realities of deployed trauma care and their systems across diverse environments. And we've got one very specific system in the diversity of continuity of combat casualty care today, Dr. Yelon. I'm excited for this episode. Thanks for joining us today as co-moderating.
Hey, Josh. It's a pleasure to be here. Being a Navy trauma surgeon, the specifics of maritime trauma care are important, unique, and have its own set of rules, I'll say. And today's guest, as you'll introduce, is an expert in all those things.
Absolutely. And that's what we're talking about specifically today. It's maritime surgery. We're focusing on how that can provide trauma and surgical care aboard ships and in those maritime environments. And unlike land-based operations, these maritime platforms introduce unique constraints that sometimes get underrepresented when we talk about combat casualty care. The limited space, the variable resources, the evacuation challenges, and that dynamic environment of the sea. And because of that, we are joined by an expert in all of those facets, Dr. Matthew Tadlock. He's deployed in a maritime surgical role. He brings expertise in operational planning and the medical logistics of coordinating all these aspects at sea. Dr. Tadlock, thank you so much for being a guest today on Frontline Surgery. We look forward to having this conversation with you, an expert in Navy surgery.
Hey, thanks for having me. I'm excited to be here. It's cool to be on the Frontline Surgery podcast. And just, I'll say one thing. So my first carrier deployment as a surgeon, I brought the first edition of Frontline Surgery with me. So that was an aid for me. And then the second edition I brought on my combat land-based deployment. So super excited to be here and super excited to be a part of this.
So Captain Tadlock, again, thank you for joining us. We look forward to our conversation today. I'll just remind all of us that we are talking to a group of surgeons and other clinical specialists. And so some of the things that we talk about may not be crystal clear to everyone. So feel free to provide some context so that it's not just you and I as sailors talking, but rather providing an educational base for all our listeners. So let me start with a clinical scenario. You're underway on a LHD, a landing helicopter dock, under alert conditions. In the galley, there's a stovetop fire, and a culinary specialist sustains burns to his hands, upper extremities, and anterior torso when his clothing catches fire. His shipmates are quick and assist him and extinguish the CS's clothing. He's brought to medical, and on initial assessment, the corpsman estimates that this sailor has a 25% total body surface area, deep partial thickness burn. So that's the scenario. Matt, if you can give us your sense of what are your immediate priorities in dealing with this patient, dealing with the alert conditions at sea, and how this may differ somewhat from land-based trauma care.
Sure. I guess, for the audience, an LHD is one of our larger amphibious warships. Specifically, it's got a flat top flight deck for vertical takeoff aircraft, so helicopters, vertical takeoff jets, Ospreys. And then the LHD specifically also has a large well deck that can be flooded for amphibious craft to send them off. And so the amphibs are designed to take Marines anywhere in the world and get them where they need to be. So that's the setting we're talking about. Normally an LHD, during routine operations deploys with something called a fleet surgical team. It's an 18-person team that augments the medical department. There also are medical providers from the Marine Expeditionary Unit that's on board too. But the important thing to understand is you got all these medical providers. It's still just a single surgeon team. So there's really, during routine operations, there's one surgeon on that team, usually one CRNA. So that's the setting. I guess the first thing I would say is you mentioned alert conditions, and I think it depends on what that means. But if the ship is threatened in any way, either under attack or there's a mishap, and the ship's crew is roaring about integrity and saving the ship, the first thing I'm thinking about is where did this injury occur and can they even get to medical? Because when the ship's threatened, medical doesn't have a say on casualty movement or how they get there. So if they can't get to medical, where is the closest dispersed battle dressing station? And every ship has essentially like a little ER where care can happen and there's supplies. So that's the first thing I'm thinking of. Can they get to me? Is the ship under threat? How are they going to get to me? When are they going to get to me? And if they can't, who is going to be taking care of them in that battle dressing station? Once they're to me, I don't think that the priorities are any different than any other trauma center. You mentioned this is a burn injury. Obviously, I want to make sure that there's no trauma associated with it too. So they're going to get a standard primary and secondary survey and make sure that there's no trauma associated with this. You want to stop the burning process, remove clothes, determine the extent of the burn. This is a 25% TBSA. They're going to need crystalloid resuscitation. So we teach people to use the Joint Trauma System CPGs. So you need to start crystalloid resuscitation. And then, I'm really concerned about, his extremity, well, the whole thing, but are his extremity wounds circumferential? Monitoring those, the risk of compartment syndrome. And then do I have comms? Because, most naval providers, in fact, Jay, I think you might be the only surgeon on active duty who is burn trained and burn experienced in the Navy. So there's not a wealth of knowledge and experience about burns. And so I would emphasize to people, once you've got things stabilized, you really need to reach out, if you have comms, to the U.S. Army Burn Center and discuss the patient and make sure you're doing all the right things. So those are my first sort of thoughts. And then the next thing is when, how, and where are we going to get this sailor off the ship so they get the best care possible? And I can talk a little bit more about that, but those are my initial thoughts, Jay.
Those are great comments, and I appreciate that. You have written quite a bit on maritime trauma. So when we talk about that, what are the injuries that the surgeon or the whole team might be seeing when at sea?
Yeah, they fall under two categories. So there's injuries that you're going to typically manage during naval combat, and that's not something any Navy has really faced anytime recently. Really, the last time the United Kingdom in the Falklands War, that's the last time there's been any evidence of total war at sea. But really, for the U.S. Navy, you really got to look at World War II, and particularly in the Pacific theater. And so, when you look at data from World War II, when ships they hit a mine, a bomb is dropped on them, naval gunfire, or kamikaze attack, and that's as closely akin to an interballistic missile, the kind of injuries that you see are, when ships blow up, you're going to get penetrating wounds from shrapnel, you're going to get blast injuries, you're going to get that concussive effect. And a large percentage, depending on the war, is 40 to 50%, you're going to see some kind of penetrating wound. And And I don't have the exact data of exactly what they were managing at that time, other than to say that there were penetrating wounds. But you can think about it. You can have penetrating chest trauma, penetrating abdominal trauma, blunt solid organ injury, all the things that you would think about when things blow up. And then a significant percentage is burn and inhalation injury. And if you look at, you know, combat at sea, there's about a 25 to 30% burn injury rate. And when you look at the kamikaze attacks of World War II, which I would think would be more similar to missile attacks now, there's an even higher burn injury rate. And so, um, those are really things that you have to think about. You have to think about traumatic brain injury. You have to think about fractures. And then, if particularly for these penetrating wounds, if it's a long time before these patients get to medical care, depending on where they are in the world, you need to be thinking about wound infections and managing sepsis. When you look at routine operations, so now that's pretty much what we've been doing in the Navy since World War II. It's very rarely, other than a mishap, that a ship is significantly threatened. The surgeon at sea has got to manage, basic emergency general surgery, the occasional urologic or gynecologic emergency, and then specific to the shipboard environment, minor burns, usually not as bad as you've described here. And then hand injuries are very, very frequent. Hand, finger crushes, lacerations, flexor tendinosynovitis. Those are things that the maritime surgeon, anybody going to sea, needs to have an algorithm and be prepared to manage. And the interesting thing about during routine operations, things happen. We looked at this a couple years ago. We looked at 50 years of data from the Naval Safety Center. They track every mishap that's happened on every naval vessel. And we looked at injury rates, and they've significantly decreased over the last 50 years. And when you compare the injury rates to other high-risk professions, mining, construction, boat building, it's actually pretty safe to be a sailor on a U.S. Navy vessel. The injury rates are far less. So that's a general overview of things that you need to think about depending on whether you're doing routine operations or, your ship's under threat.
Yeah, thank you for that. Those are great insights to both the um, operational environment, but also routine maritime operations, because the ship is a high risk environment, right? There's a lot of things that go on that are um, at significant risk or potential risk for injury. So those insights are really great, and I appreciate those. One of the things that's different than land-based care is the tyranny of distance and time. And so how does the surgeon prepare themselves to deal with those situations? You have a patient on board that is going to need a higher echelon of care. What are the strategies, the outside the tent skills that surgeon needs to facilitate the movement of that sailor?
Yeah, one of the things to think about, if you look at like the history of the navies of the world and naval combat casualty care, particularly at the age of sail, being a surgeon at sea is originally one of the original sort of austere forward surgical teams. It's less so now because ships aren't under threat. But I mention that because your primary mission, of that warship is not to take on casualties, is not combat casualty care, is to serve whatever mission you're serving and maintain combat effectiveness. And so for that reason, any decision to operate or to do anything has to be approved, and it's ultimately the commanding officer's decision. So you mentioned outside the tent skills. So whether it be routine operations or not, your ability to clearly communicate, um, to recommend to pull the trigger for a medevac at night if you think that's necessary, because that's a dangerous evolution. Your ability to clearly communicate with your senior medical officer and the leadership of that ship, and oftentimes, like in my experience, you as the surgeon, you're the only surgeon on the ship. Usually, you often are directly advising the commanding officer. It depends on the structure. And so, really clearly understanding the operational environment that you're in and clearly communicating is so critical and important, because if you're a surgeon who sort of is only around when needed and not part of the medical department and not part of the ship's crew, well, when it matters, your recommendations may not be listened to. So that's I guess, a really important part. And we as trauma surgeons understand that because, we work in systems, we may be a trauma medical director, that communication with our colleagues is so critical. The other thing that you have to think about, so if you have a patient, whether it's a traumatic injury, it's a burn, it's emergency general surgery, whatever it is, you really need to understand the options of where they're going to go. And is the expected best and worst outcome what that's going to be at, say, a civilian hospital in a foreign country? Like, is that hospital really going to be able to provide better care than you can until that you can get them to an allied or US-based facility? And so that's a really hard thing to do, and it varies depending on where you are. I'll give you an example. So there was recently, I know of on a ship recently, there was a fire, sailor had an inhalational injury, and the surgeon and the medical department had to decide, hey, do we put this patient on a short helo ride to a country where we've sent people before, but they don't really have a burn capability, and they have a small ICU, or do we take the risk and put that patient, who is intubated, by the way, on one of the fixed wings? It's called a COD, a fixed wing plane, catapult them off the carrier, and then send them to a country where we have people, we know we can communicate with the hospital, and we have a better idea of the care. And those are sometimes difficult decisions to make. In this case, they decided to send them to the known quantity once the patient was stabilized, and they catapulted them off the carrier. And so that's the constant decision. Can I provide the care needed? And if I send them off the ship, is that care going to be better than what I can provide?
Yeah, I want to go a little bit further on that, Matt. So I think you highlighted some of the operational issues. And I think the only way to orient oneself as the surgeon to provide advice and counsel to the commanding officer is really having a solid understanding of the pathophysiology and natural history of the disease that you're dealing with. So it's incumbent upon the surgeon to really understand what the disease process is, and then bring those other observations into your, I'll call it your OODA loop in decision making about host nation hospital, US Role 3 facility, and all those other decision makings. So, we typically see relatively junior surgeons in these roles on these large platforms. I just want to sort of emphasize and get your take on really understanding the natural history of trauma, the disease process, and the pathophysiology, all while understanding the resources that you have on the ship.
Yeah, you could talk a lot about all of that. So, yes, 100% I agree with you. One of the first things that you need to do as a surgeon on any kind of maritime platform, whatever you're on, whether you're supporting an aircraft carrier, one of our amphib vessels, or you're on one of our Navy austere surgical teams that is meant to provide a surgical capability on ships that usually don't have it, you really, it's incumbent upon you to have a really good understanding of not just whether you have the right surgical instruments and staples and all that kind of stuff, but what's your blood capability? What is your ICU capability? When are you going to run out of drips, etc.? Because you need to have a swag of that before advising anybody. And a lot of that's your senior medical officer's responsibility on your ship. But often those caregivers, they're great, but they don't have a lot of injury experience, critical care experience, and often the person with the majority of that experience is the surgeon. So you need to also understand when you're going to run out of resources.
Yeah, I'll interrupt you there for a moment, Matt, because part of the resources is your crew. and crew resource management and how you're going to deal with the personnel that you have to provide this austere care for the patient. And that really gets us into the next lane that I want your comments on is about prolonged care, keeping a patient on the ship and providing prolonged casualty care for the patient at sea.
Yeah, and it really depends on the team that you have. And so there's three general flavors, and I kind of alluded to them just in the previous question of surgical teams. So at any one time, there's 20 maritime surgical teams that are potentially on a routine deployment. And then when you add the ERSS, there could be more depending on what they're supporting. But like for example, on an aircraft carrier, to your point, your your team, at least the surgical team, is you as the surgeon, two or three surgical technicians, and a CRNA. There's one nurse on the ship who is maybe ER or critical care, but they're the only nurse on the ship and they have a lot of administrative challenges. So that's what a carrier looks like. So a lot of the people supporting you, particularly post-operatively or monitoring, are going to be corpsmen. And so, we're used to, I don't know, some of us in training are used to in the hospital relying on the wards and the ICUs to do their job and all those kind of things. It's really incumbent upon you and the surgeon to really be involved and track and go see the patient, teach your corpsmen, and make sure that all the right things are happening. Fleet surgical team has a little bit more capability. It's similar. It has a CRNA, but you also have a perioperative nurse, and that's unique to the fleet surgical teams. And in my current role, I'm in charge of the West Coast fleet surgical teams, and I didn't really appreciate how important an experienced perioperative nurse, both in the hospital and in the operational setting, can be for your surgical team. And comparing to the other maritime platforms I've been on the carrier team, on the carrier and on the ERSS, or even with the Marine Corps, like you are right now, Jay, is that lack of that perioperative nurse expertise in terms of austere sterilization and their just level of knowledge and experience is a gap for some of these teams, and I think it's underappreciated.
That's a huge component. And please forgive me. I just have to ask this from the non-Navy side. Most of the components you just talked about from both of you were a single surgeon team. And then you also said you have to understand the physiology of what's going on with your patient, casualty or not, to affect your ability for those professional leadership attributes. And then you simultaneously talked about the limited evacuation, which I feel like begs the question, with a single surgeon team and a large amount of potential patients, what about non-trauma surgical care? What about emergency surgery? How does that come into play with understanding physiology, limited evacuation, and only being one surgeon? How does a newly trained surgeon be prepared for that breadth of potential catastrophes?
Well, so one thing that we've done, yeah, in the Navy medicine has an operational clinical community. And for the last 5 or 6 years, I've chaired the fleet surgical community or sub community. And we've really tried to tackle this because fundamentally, and I think it's somewhat similar in other services. You're a junior surgeon, you're assigned to a maritime platform, and there's no formal mentorship available at all. And so we've created this program that does a couple of things. And it's really modeled after, the JTS combat casualty care call, where we've done a couple of things. So, if you're assigned to a fleet surgical team or a carrier, number one, if you do a procedure at sea or perform surgery or send somebody off the ship for surgery, you need to log that and submit it to a centralized database, because that has never really happened until about 4 or 5 years ago, until we started this program. So that's the first step. The second step is we now hold monthly, we call them Maritime Surgery Quality Improvement Program conferences, where surgeons basically, if they had a difficult case or a challenging thing, they present that, and everybody, all the other surgeons all over the world, like we just had one yesterday, So we had people calling in from deployment, s- some in places in the news. We had people calling in from Japan. We had people calling in from Europe, East Coast, West Coast. And we converge and we talk about these challenging cases. And what happens is, and then often senior surgeons are on the calls too. And what happens is we've created a mechanism for that formal mentorship, and that wasn't happening before. The next thing that that program does is now we're starting to have actual outcomes data. And we're going to publish the first paper in the military supplement of JTEX this summer. And it's not a lot of patients, but now we have, 30-day outcomes and 1-year outcomes on mostly emergency general surgery stuff. So now you as a surgeon have a tool and you can use that outcomes data to communicate up your chain of command on what you should and shouldn't be doing. I'll give you one example of and I don't know what happened here, but where the wrong decision potentially was made. One of the things that we have to take care of, like I mentioned before, that is a little bit outside of our skill set as general surgeons is, hand injuries, gynecological emergencies, and urologic emergencies. Managing or triaging potential gynecological emergencies are actually quite frequent. And recently, in the recent past, one of the surgeons had a young woman coming in with abdominal pain, and he was concerned about ovarian torsion. And he wanted to take the patient to the operating room for a diagnostic laparoscopy. And that, we have endoscopy and laparoscopic capabilities on our bigger combatant vessels. And I don't know what communication did or didn't happen, but the senior medical officer didn't agree with the surgeon's diagnosis and recommended to the commanding officer, no, that we not do this procedure, and then we wait till we pull into port the next day. And because we're going to be able to get that patient to a U.S. emergency room. And that was the decision that was made. And thankfully, when the patient got off the ship and they were seen, they did not have ovarian torsion. And so nothing happened there. But I used this forum to sort of talk about that case because, in my opinion, the absolute wrong decision was made. And we're trying to create outcomes and case stories and resources so that surgeon can advocate and do the right thing. And so it's challenging. It can be challenging at times because most of the time, during routine operations, you're not dealing with a lot of sick and injured patients or some of these acute conditions.
Matt, thank you so much for giving us really a sense of the true complexity of maritime surgical care, both trauma and other. And it is truly a complex environment, and you're dealing with a lot of stakeholders, which makes it even a different level of complexity that most of us don't deal with on a routine basis. So now we're sort of at the part of the discussion where I need you to provide our listeners with some advice. What kind of training is essential for surgeons practicing in the maritime environment, understanding the tyranny of distance and time, understanding the shipboard medical capabilities? In that, what's the role of rehearsing to deal with emergencies? And what's your best advice for building relationships with the ship's leadership?
Yeah. So a couple things. Um, you as a surgeon, you're a naval officer, and you really need to, it's difficult, right? Because when you're not deployed, you need to be at the hospital and you need to be operating and taking care of patients. So one thing that you can do is really focus on getting members of your surgical team to the hospital with you and working together as a team. That does a number of things. They get to know you, you get to know them. You're making sure that they're getting skill sustainment. And that's the first part, building those relationships. You really need to try, particularly if you're assigned to a carrier, to be the go-to for elective surgical problems for your ship. Have a clinic on the ship. Make sure that the people know that if they've got a surgical problem, they got to come to you. It's just like private practice. When you want people to consult, you got to be available and affable. And hopefully, you have the ability because you were well trained. And I don't think it's too dissimilar, but you've got to be a presence. You've got to be there. And then eventually everybody in the ship will get to know you, particularly on deployment. One of the first things you have to do is you've really got to do, in the Marine Corps, we call it a limited technical inspection. You've really got to understand all of your gear and consumables and trust but verify everything, because during a bad day at sea, you don't have it. That can be problematic. And then you talked about rehearsal. So one of the big things about the Maritime Surgery Quality Improvement Program that we emphasize is appropriate surgery at sea is safe. So if you're deployed underway and somebody comes in with an appendectomy or something that you can handle easily, you really need to try to do that while underway, because that is just one aspect of getting your team ready for a bad day when a mass casualty happens or a mishap, or you end up taking in combat casualties for any reason. The next thing I would say is, particularly as a single surgeon team, you need to be heavily involved in the mass casualty exercises on your ship and really understand the capabilities of each dispersed battle dressing station on your ship. During training exercises, be one of the teams that goes out to those places, trains the corpsmen or the providers that are there, and really understand casualty movement through the ship, particularly if it's threatened, because it can be challenging depending on the ship that you're on. You have to carry patients up and down ladder wells. Sometimes you have to hoist them from deep down in the ship and really learn and understand that, because I think it'll help you better train the corpsmen and other people working for you. I think those would be the first things that I would say. And one thing we haven't really talked about is the patient transport through the ship, whether you're on a carrier, on an amphib, or on a smaller ship as part of a augmented surgical team. That can be time consuming. It can be difficult, and you need to practice it with the ship's crew and understand it.
So, Matt, after spending over 20 years in Navy medicine, give our listeners sort of an understanding of the breadth of potential scenarios the Navy surgeon might be met with.
Wow. I mean, it's truly anything that any expeditionary surgeon might manage. If you watch the news in the last few years, the Red Sea, currently what's going on with the epic fury, the Iran conflict, and the Strait of Hormuz, you've got to be prepared for anything. I think in the maritime environment, like I've said before, hand injuries, septic joints can happen, and people have had to do open arthrotomies, particularly of the knee. I've mentioned the gynecological emergencies, specifically ovarian torsion, ectopic pregnancy. Occasionally happens. Understanding hemorrhagic ovarian cysts, testicular torsion can happen, and then the full breadth of emergency general surgery and trauma care. If you're talking about naval combat, I think a big weak spot for all military services is burn care, and you really need to brush up on that. And then you need to be thinking about, you know, prolonged holding of all of these patients and how you're going to do that. And if you don't have the long-term resources, make sure you're clearly communicating that up your chain.
I appreciate those are great comments. I'll just follow up your comments with, in your career, what unique missions have you been on?
Yeah, so I've done the full gamut. I've done the carrier surgical team. I've done the Role 3 combat hospital in Afghanistan. I've been on an austere surgical team. So our ERSS, the 7-person single surgeon team, supporting naval special warfare mission on a destroyer. That was pretty interesting. That happened right as the world shut down for COVID, and all of our original evacuation plans went out the window because nobody was accepting patients. And so we had to sort of change our calculus if we had had casualties for what we were supporting. So that was really interesting. And I really, really came to personally understand the tyranny of time and distance, because it was going to be several days before we could pull into a port where we could get those patients. Probably one of the most rewarding and interesting things that we did is I was able to be part of the medical team and the 2 surgical teams that participated in the Artemis recovery mission, a few weeks ago. That was pretty interesting. Got to learn a little bit about some of the physiology of space flight. And the Air Force has a course that for pre-hospital providers that gives you basics that I recommend that you take. And then being part of planning for that. Now, thankfully, it went well, but we weren't just planning to take care of the astronauts should something happen, but really, it really is a complex operation involving, helicopters and Navy divers and recovering the capsule over a long period of time. And it went flawlessly and there was really no problems, but we were also, preparing for those contingencies as well. But that has to be comes to mind as one of the most uniquely rewarding experiences that I've been able to participate in my career in the Navy. One important thing to remember is, surgery at sea is not just for the Navy. More and more, we are training and integrating Army surgical teams on our warships. We're integrating, the Canadian Armed Medical Services. We're practicing with Air Force units. So, maritime surgery is a joint problem, and more and more we're going to be working in that environment together across the services.
Matt, I truly appreciate your insights. I'll shamelessly plug your textbook on maritime surgical care, and we'll put those in the show notes, a link to that. Maritime surgery represents a critical component of distributed operations. As future conflicts extend into the littoral and maritime domains, surgeons must be prepared to deliver high quality care in these unique environments. Understanding how maritime platforms integrate into the broader trauma system is essential for readiness.
Well, thank you so much for joining us on Frontline Surgery. And we were just honored to have you, Dr. Tadlock and Dr. Yelon, just experts representing the Navy Navy surgical care, and that whole continuum of combat casualty care. As you described, these maritime environments just demand adaptability, preparation, teamwork, bringing people back from space. What a phenomenal breadth of experience you can have as a naval surgeon. And by understanding these challenges, clearly you're ready to deliver life-saving care wherever possible and wherever the mission, whatever variation that mission takes, may take you and the surgical team. So thank you so much for all the listeners. Hope you enjoyed this on one specific aspect of unique military trauma care. Until next time, stay sharp, stay ready.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.